Good morning, everyone. We'd like to welcome you in the name of Redetsa to this 51st webinar of the program of Redetsa. In this case, we're going to talk about shared risk assessments, learnings from the implementation. Learnings from implementation. This webinar is going to be done in Spanish. If you'd like, you can select the language. In the lower part of the screen, you're going to be able to hear the interpretation in English. The original is going to be in Spanish. This session is going to be recorded as any of the Redetsa webinars that you're going to find later in the Redetsa website and in Pau TV in YouTube. Without further ado, then I give the floor to Alexandre Legruver, the Chief of Access of Medications and Health Technologies of PAHO. Good morning, Alexandre. How are you doing today? Good morning, Marlene. Thank you very much. Good morning, everyone. Thank you for your participation in this webinar. A few weeks ago, we were here in the webinar number 50. Now we are in the 51st webinar today about these shared risk agreements. Thank you very much. It's a very interesting topic. I would say that it's also a topic a little bit controversial, and at least I love these points that are controversial. So this is precisely why we're having these debates, this exchange of personal experience, and there are some that are very exciting or excited actually about this topic of shared risk. And I believe that this is one of the tools and one of the methods, a strategy that actually increases the possibilities of access to health technologies. Some others are very critical that there is not enough data available, especially in the region, in order to move forward with these kinds of strategies, that they are more interested in the industry and so on. So I'm getting a little bit ahead about these these opinions in favor and against, but I'm not going to place my opinion here about this, not right now at least, and without a question. This is a complex topic, a topic that actually deserves a discussion and exchange of experience between us. And we know that many times we check international experiences. And I believe that one of the first institutions that has used this several years ago, they were using this about short risk assessments. And if I am not mistaken, the first experience was extremely negative, and there are some other success cases on the other hand. So I believe that there is not a single um, silver bullet, like, and that's why we brought this topic and brought it to discussion here. I wanted to get ahead of myself and greet right now our speakers that we're going to have today. We have Juan Yangela of NICE. Welcome and thank you very much, Juan, for this invite. Also, Rodrigo Severino from the Ministry of Health of Chile, and yes, Luis Vrostodoy of the Ministry of Health of Argentina. And I would like to also greet my dear Inquirio Pretungrado, that is also with us today, with the team from Argentina that are always very solid there in the assessment of technology. So thank you very much for your participation from the Argentinian team here in Redetsa. So without further ado, I'm going to be short. I wanted to say that this topic about including HTA health technology, sorry, and that the evidence is always in constant evolution and is extremely helpful, and that there are restrictions of prices. This is something common in the health systems in the region. So that's why the challenge of these health systems are more recurrent and getting to new mechanisms for this decision making, looking for more flexibility for this decision making for coverage. And in this very complex context, these share risk agreements have been used as one of the tools to help facilitate this process of yeah, helping with the access under very specific conditions in engaging with this structure with the impact to the budget. However, as I mentioned at the beginning, this implementation of these two has several challenges that are very significant in terms of design, monitoring, and availability of data, capabilities of the institutions, right? Because having um, shared risk in monitoring and different activities, for example, includes obviously the needs that these monitoring systems should exist and being implemented. And we know about the challenges in our countries. Many times we do not have data, so we can have these monitoring systems as we should have adequate in these kinds of situations. So our objective today is to get to learn from these experiences in the region. In this case, we're going to have experiences from Chile, Argentina, and also an experience in a country that you could say that is a little bit ahead in the years, has a little bit more experience, more years of experience in the years of this. So we can learn a little bit more about this experience of implementation in different contexts, in different characteristics of these systems of health, and so we can contribute with the exchange of knowledge in the region. Today, the moderator that we are going to have is my colleague, Hamid Iqbal, and that is going to be present here. I wanted to give the floor to Caroline. Thanking for the moderation and thanking once again each one of you for your participation. I wanted to tell you that we have more than 200 people connected, so you can see the level of interest on this topic in our network. So thank you very much, everyone, and thank you very much for your participation, the speakers, one more time. And I'm going to give the floor to Caroline. Thank you very much. Thank you very much, Alexandre. Thank you for your words and this opening. Good morning, everyone. It's a great pleasure to be moderating this webinar today. As Alexandra mentioned, we're going to present different experience of shared risk agreements because we're going to see how they are implemented. And first of all, we wanted to have Juan Anguila of the National Institute for Health and uh, Excellence of the United Kingdom, NICE. He's going to tell us about these kind of agreements in the Institute. Juan is licensed in biomedical sciences by the University of Manchester. He also has by the University of North Carolina. Currently is NICE advisor, NICE International, has experience in economy of health and assessment of effectivity, and in his current role is supporting the pharmaceuticals and medical technologies in the planning of generation of clinical evidence and economical evidence, and helping also with the countries to strengthen the assessment processes of health technologies. Go ahead, Juan. Thank you very much, Caroline and Alexander, for your introduction. It's a great pleasure to be with you all and sharing experience about the agreements, these short risk agreements, and talking about the experience that we have had in these kind of agreements in NICE. I'm going to share now my presentation. Can you see my presentation now? Yes, we can see it. However, we don't see it full screen. Okay, now we can see it. Okay, perfect. And All right. So before we get to talk about the shared risk agreements, I'm going to talk a little bit more about the decision-making framework that we use in NICE that is very specific. We are directed mainly by the ISER, this incremental cost effectiveness ratio. And what we do is to compare the cost of a new treatment compared with the general pattern of care in the current system. And we can see the additional cost that we have for every new year additional with the health quality that is generated with the new technology. And what we do is actually use a range between 25,000 and 35,000 pounds for every year of life adjusted to quality. And why do we use this threshold that is not fixed, but it has a range instead? Is because we're taking another kinds of criteria when we move within this range of 25,000 to 35,000. If there is a lot of uncertainty, we are going to accept one that is closer to 25,000. But if there is more uncertainty, or if we have evidence that a technology can reduce inequities, then we are going to get closer to be able to accept a threshold much higher, closer to 35,000 pounds. So then this threshold is what we use as the first measuring tool at the moment of decision making about financing or not certain technologies in the UK, and I mean in this case England. It's important to say that when NICE is assessing medications through their program of technology appraisals, if NICE recommends something, the implementation of this health technology, this medication is mandatory in the natural system of health in a period of 3 months usually. The recommendation of NICE has a lot of strength because it's connected to data of financial support. And then once the company provides the information and evidence, this is assessed by an academic group, and then an independent committee assesses this evidence from the industry, as well as any evidence or the assessment provided by the academic group. And the committee generates a recommendation based on this threshold that we mentioned between 25,000 and 35,000. Which kind of decisions can the committee have? And in this place, it's important to mention flexibility. Alexandra mentioned at the beginning, and we can have several options. It could be positive recommendation about cost-effective technology within this threshold. It could be negative if the technology, for instance, might have an ISER of 48,000 pounds for a year of life adjusted to quality. It's a little bit beyond what we are eager to pay, and hence it receives a negative recommendation. Another option is an agreement of managed access. That is the most common way in which NICE does something similar to a shared risk agreement. And this managed access agreement is a provisional recommendation to use a technology with public financial support, conditioned to continue getting evidence about how the technology works in real life. And then we have a new assessment a couple of years later after collecting evidence, so we can determine if we can provide a final, definitive recommendation. And this second evaluation or assessment is going to decide if we are going to continue financial support or if we remove it after seeing it's not cost effective after collecting more information. We can also have some optimized recommendation, as we call them. What we do is recommend a technology for a specific group, not cost effective for all the population. It's a little bit more restricted. However, this is for restricted population, people with a specific mutation within oncology pathology that we have, for which technology works better. And then in some exceptional cases, we might have as well recommendation in research only. This is rarely used, and today we are going to focus on the third recommendation for managed access and data collection. And It's important to know that when we talk about the evaluation of health technologies or health technologies assessment HTA within NICE, we don't provide an assessment at a fixed price. We don't say this technology is worth this much and we are going to see if this is cost effective at this price. But what we actually do is to use this assessment process for health technologies to establish the price of technologies. And this HTA is provided in three steps. As I mentioned, we have a threshold between 25,000 to 35,000 pounds. So the first thing the committee does is deciding whether within range what is going to be the threshold for this specific thing. If there is uncertainty, 25,000. If there is less uncertainty and let's say impact on equity, we're going to get closer to 35,000. When we establish this threshold and we build this cost effectiveness model, then what we do is to see how we can negotiate with the pharma company so we can get the price of this medication to a price that makes it cost effective compared to the threshold that we selected for this. And based on this, we make the recommendations. So the process of assessment of health technologies, what it does is inform the commercial negotiations between NHS England, that is the organization that is managing at the national level the health system in the UK, and pharmaceuticals. And this is informed by this assessment provided by NICE. So what we do is, as looks here in this slide, we try to take through negotiation this price down so it can be cost effective. How do we do it? We do it in different ways. We have something that is called patient access scheme, the PAS, that basically these are discounts. These can be simple discounts. We apply a percentage of discount, in this case, to the medication in a way that it makes it cost effective. We could have more complex agreements like price, volume, and then we could also have some managed access agreements. So what do we do there? In this managed access agreement, the MAA, what we do is a simple discount or a more complex discount that could be price, volume, it could be a specific dosage that could be provided for free. It could be based on results. We have in here several models for these agreements, but this is conditioned that we can collect data in these provisional recommendations. So we can say there is a lot of uncertainty in this recommendation, so we provide a provisional recommendation to collect more data. We negotiate through this period a price. This is a price range that lowers the cost enough, so even with all this uncertainty, we can make sure that we can still pay a cost-effective price. And then after several years data, we reassess the technology to see if we can recommend it in a routine use. So as I was mentioning then, this managed access agreement MAA for NICE is an agreement with a limit established that is temporary and in which we collect data, and a commercial agreement that is going to make sure that even in the more adverse scenarios, we are going to continue paying a price that is cost effective during this period of data collection. What is the main principle directing in these agreements, in these managed access principles? These are the main principles informed by the first experience that we had with these managed access principles in the last decade. At the beginning, we used to have a fund of managed access for oncology therapies in 2012. But in the last couple of years, we have developed a fund that help us finance this managed access with non-oncological therapies. And so the ones that we have to direct this have to do with equity between oncological and non-oncological therapies. And another of the objectives is to focus on the medications that are actually promising. And in the ones that we're collecting more data is actually going to solve uncertainty. For instance, if we do have a therapy that is very innovative, however, that the cost effectiveness is not going to be different if we collect more data. For instance, we have very mature data about mortality, free of progression, and total mortality. And then we have very trusted data about life quality. If we collect data long term, it could change a little bit, but we are pretty sure that this estimation of this ISO is not going to change too much. So it can be promising or not. However, collecting more data is not going to change our decision. So it might not be a candidate for this kind of managed access agreement. However, several of the new oncology therapies that have very promising results of survival, but if this pivotal test has only about 8 months, then we might have enough maturity in these Kaplan-Meier curves to see how the disease is going to be developed long term, and then having, in this case, an managed access agreement and seeing how it works long term, we could reduce uncertainty about this. So this is the kind of therapies that we're focusing on. It's important to know that we have to focus on promising therapies with uncertainty, with the potential, however, to be cost effective. If a therapy even doing some early moderation, we see that even mortality might have a very positive profile. Even if this could happen, we are not going to make it cost effective because it could be too expensive. The implementation of such technology is too expensive. Then it might be the case that there is no potential for cost effectiveness long term, so it wouldn't be a good candidate for these kind of agreements. When we provide a recommendation of using through a determined period of time, we need to make sure that this is the shortest time possible so we can solve uncertainty. We do not want to have this conditional recommendation through a very long time without getting to a final conclusion. We have to collect data as fast as possible in a period of a maximum 5 years. Another important aspect is that when in this kind of agreement, all the patients that comply with the criteria of financial support established in the recommendation of managed access have the right to receive this treatment. And I am going to explain later why this is important. By the end of this managed agreement, then we are going to update this information. We recommend, we collect data, and we do a later assessment where we are going to provide further information. So we can have this recommendation of managed access, and we collect data, and then if it is negative, the patients that have started the treatment during this period of managed access might be receiving the treatment even this negative recommendation in the second assessment, and the company is going to cover these costs. This is important because in the first agreements that we had about managed access, there was no close to leave this. So there was a lot of uncertainty between the patients that started the treatment within these managed access about what was going to happen if the final recommendation was negative. So this was a good learning process, having exit criteria very well established so we can provide certainty to the patients that once it finishes this recommended access, even if it is negative, if the clinician, even though it is not cost effective, if they believe that the patient could be benefited, even though for population it might not be cost effective, for the patient we could provide financial support so we don't stop the personalized treatment. How do we finance these agreements? As I mentioned before, when NICE takes a financial decision, it is mandatory that the health service finances this. And we start with the financial support of the health service. In the case of a recommendation of these managed access, these medications are financed with separate funds. We have a fund for oncology therapies, and we have funds for innovative therapies that are non-oncological. Each one of these funds has a budget of 340 million of pounds per year, and this generates this threshold of what we're going to have in these funds. Why is important? The principles that we mentioned before, that the whole population is going to have the right to have access to these medications, because even though this is a fixed budget of 340 million pounds per year, it's never closed. If we have more patients, what we do is add patients until we get to the threshold. If we get a more expenditure than this limit of budget, what we do is a conciliation with the pharmaceuticals, so they return money in a proportional way to the patients that will have been treated with the different medications that we have in the fund. It provides certainty, and at the same time, it helps us continue including patients without denying access to new patients that are entering. About the number of agreements that we have done of this kind, we have signed 72 since 2016. That is when we created the new version of this oncology therapies fund. In January 2026, we had 9 therapies that were collecting data. We have 10 therapists that were doing the second evaluation of or assessment of the collecting data, and 53 had just left from this managed access agreements. From these 53, 33 received a positive recommendation. 3 had received a positive recommendation, but only for a subgroup of the population. 2 had received a negative recommendation, and about 5 or well, they had removed the recommendation, or there was no request of the company to reassess, and hence we were not reassessing. Finally, I would like to mention that everything that we do once we start any assessment of a technology is that we do an analysis of feasibility of these shared management assessments. We need to check the uncertainty that we have in data to see if we can solve this with expanding the collection of data for more time. For instance, if the pivot test had a follow-up time that we can use, so in 2 or 3 years we can have more mature data. If we have data sources of real life that we can use to provide this follow-up without adding more work to this health system that is already overloaded, and we have to check whether it's feasible to implement this in a temporary way without creating a lot of additional work for the clinicians, of collecting data, of changing the way in which we manage service that might be not remain through time if the therapy is finally not recommended after reassessing. And it's extremely important to see that this is feasible before we recommend this shared uh, managed agreement. And once we do this recommendation of managed agreement, it's important to have an agreement of collecting data that is extremely clear, where we are going to establish the duration of the agreement, the patient population that is going to receive the therapy and data collection, which key uncertainties we want to solve, and more, for instance, mortality, progression, and total mortality. But sometimes we need to collect data about life quality. How often do we have secondary effects, and the cost of treating these secondary effects in the health system? We also need how often we are going to have these data cuts to provide follow-up and to check if we have enough information for decision making. And obviously, we take everything that has to do with legislation, governance of information, and data protection, as well as considerations of how we're going to publish this information if the pharmaceutical is interested publishing in scientific magazines. And to close, when do we close this period of data collection? What we do is reassess through NICE. And it's important to highlight that what we do is not only see if we have complied with the objectives that we had selected, but we have to actually do a new analysis, because if we had recommended a therapy 5 years ago in this managed access, and then in 10 years we check this, the standard might have changed, so the comparison to see if it is cost effective to see compared to what we already have might have changed. So we need to do a new assessment, establish everything well based on what we have at that point in time in the health service, and then provide decision making once again based on this situation. And then in here, we can have a positive decision, optimized decision for a subgroup, or a negative decision. And we can never go back to establish a managed agreement after leaving one previously. And this is the end of my presentation. Thank you very much, and I'd be happy to answer your questions later in this session. Thank you very much, Juan, for your presentation. Very interesting, of course, understanding how we have these agreements, the experience and requirements, as well as collaboration that we have with the health systems and clinicians so we can implement this. If before we continue, I wanted to remind you that you can leave your questions in the Q&A section in the lower part of the screen, and then after the presentations, we're going to have some space to discuss and answer all of them. So we're going to get to our second speaker, that is Rodrigo Severino from the Ministry of Health of Chile. Rodrigo is a nurse, is his profession. He has a master in health management and epidemiology from the Pontificia Universidad Católica de Chile. He has specialized training in medicine based on evidence and economic assessment of health technologies. He currently works in the Unity of Economic Assessments of the Department of Assessment of Health Technologies and Health Based on Evidence of the Ministry of Health of Chile. And in there, he's participating in the design and implementation of policies of these short risk agreements for high cost technologies. Rodrigo, you have the floor now. Thank you very much for this kind introduction and for the invitation for this to this webinar. We can see your screen right now, however, it's not full screen presentation mode. Okay, now we see it. Thank you. Okay, perfect. And nowadays, apologies for this. Nowadays, we know that we have a lot of tension between the sped up rhythm of pharmaceutical innovation and the responsibility of the states, the government, and authorities so they can guarantee access to the patients, for the patients to these medications and the system. And this tension many times is not sustainable for both parts, the industry and the state. And if we think about this, if we continue operating under these traditional models, at the end of the day, the ones that are more affected are the patients. But the challenge that we have in the health systems is not a new problem. It's something that more than 120 years ago we had pharmaceutical companies that offered giving back their money if the product was not working as they were promising. This was the no pay in the no cure no pay in the most literal sense. And many time later in the 2000s, Klaus Mantrum retook this idea under a logic that is very different. First of all, it starts placing layers about analysis about the expenditure and incentive, and it provides a structural exit to this attention. And basically, this is what is being collected from these shared risk agreements. For those of you that are not familiar with this concept, and shared risk agreement is an agreement between a manufacturer, a provider, or a payer that allows for access and coverage with reimbursement of a health technology with specific conditions. We could have several mechanisms to solve uncertainty, the access of technology, and to manage the adoption in order to maximize the use and limit the or budget limitations. And when we check literature, the most common classifications are these agreements. Result-based agreements and financial agreements, although there is literature about the classifications about service-based agreements that are basically the ones that the pharmaceuticals offer as opportunity programs. And before we go to the learnings that Chile has had or has now about the implementation, it's important to understand where are we coming from, where we started, and this was born in about it was about 2023, 3 years ago, even though in 2015 Chile has a law Ricardo Soto, that allows for financial support, uh, eh, health situations, and technology of really high cost. And at some point of the law, it establishes that we could manage innovative contracts or shared risk agreements. But until 2023, we had the political willingness to generate institutional support to this. At that time, 2023, we started having these training workshops in a technical cooperation of the Ministry of Health with the Pontificia Universidad de Chile, where specialists in these topics trained workers about the shared risk agreements. We started creating international agreements, strategic partnerships between Chile, Argentina, and Spain, where the main objective was to share knowledge. About technical management, the Ministry of Treasury asked through the World Bank consulting report where they generated a proposal for the implementation of shared risk agreements in the country. This proposal is the base on which we are working from the ministry so we can generate institutional support so we could have this pillar on over which we could generate these kinds of agreements. In 2024, we requested an extension of the budget, and we created a unit for shared risk agreements in the ministry. And this unit was born in 2025 and is the one that we currently have working on the technical guidelines of directives of this strategy and the strengthening of this. And in 2026 now, we have been signing and executing several of these agreements. And the agreements we have so far are four that are publicly known. Sorhesma Balatrohem is a shared risk agreement with a clinical result, um, cystic fibrosis, tentrominosemab for chest cancer, Ingomilugnab for multiple recommendations that is a financial agreement. Four of these agreements executed might seem few, but for a system that started from zero in 2023 is enough to learn several things. And the first learning that we have that is important to highlight is that institutional support is necessary but not enough. Having a law and office does not guarantee that the agreements are going to get to a good end if there is not qualified people with exclusive dedication with a shared risk agreement that is not well designed is even worse than not having any. The second learning that we received is about institutional memory. This model cannot depend on people that started the process. We need the processes to be standardized, explicit guidelines, criteria for living that are clear, and if the team leaves tomorrow, the system needs to continue working. Next one is about the symmetry of information. The manufacturer and pharmaceutical knows very well the product more than anyone, data, models, projection. We know better the health system and population. Hence, managing this asymmetry is not something that has to do with negotiation, but technical issue and has to be solved before we sit to the table to negotiate. And the fourth place, the fourth learning that might be the Achilles heel is the clinical data and agreement based on results without interoperable systems of follow-up. It doesn't make really sense because it's not an operational detail. It's the heart of the agreement. If we cannot measure the result, we cannot cover any kind of contract and respect any of them. The fifth one has to do with multi-actor governance. The real feasibility of shared risk agreement is not defined in the ministry or in the office where we signed. Hence, it's mandatory to engage actively with all actors. In the case of Chile's, the one that is for purchasing, then and then the networks that are going to implement in real life the agreement. This is why we believe that this integration from the original design ensures the operational feasibility of the agreement, but there is a step that is before everything that is very technical. But if we skip this step, all these steps make no sense. This step is risk characterization. Before we structure any kind of risks, short risk agreements, the purchaser needs to answer three questions. First one, which kind of uncertainty is the one that they are having? How much is it going to be spent if the technology works in real life? Is the value paid justifying the price that the provider is requesting? Second, how big is the uncertainty? Can we manage it with available data, or do we need to generate new evidence? Third one, which tools do we need due to the diagnosis that was provided before? Only when we have an answer of these three questions with a technical answer that is not commercial, not political, but technical, the design of the shared risk agreement can be taken. If there is no previous agreement, any indicator of follow-up is going to be an arbitrary indicator, and the objectives of reimbursement is not going to have any kind of foundation. But now, the question that we have next is about which kind of uncertainty is the one that I am facing. And the answer is going to help us distinguish two natures of the risk origin that are not variables of the same issue, but are different issues with different logic and different tools to be managed. The first one is financial risk. That is basically an uncertainty of the budget. The question here is not if the medication works, the question is how much is the system going to expend. And it depends on three variables that no contract has the ability to establish. First, how many patients are actually eligible, how much time are they going to use the treatment. That is going to depend on the general survival of the patient, if they progress with this, if there is toxicity that stops the treatment, and if the therapy migrates to patients that were not considered originally in the agreement, like the off-label use.
And there's something that's counterintuitive that's important to highlight, which is the unitary price. And this is the core of the whole negotiation. And the only constant variable is that once it's signed, it does not disappear. So you have to understand that the financial risk, the real one, does not live within the invoice of the unitary product, but instead it lives in the biology of the patient and the epidemiology of the disease. And the tools for characterizing this risk are, for example, budget models, scenario analysis that allow us to estimate the distribution of possible expenses and to define at which point, in which point of the system, there's going to be a difference. The second risk is the financial risk or value uncertainty. The question changes here, and it's not how much we're going to spend, but instead how much, if what we are spending is going to generate the value that justifies our spend. We know that health economy value is health, so the risk uh, translates into the real clinical benefit. What this justifies the incremental cost that the manufacturer is asking for. It's important to not confuse these two types of uncertainties. We need to understand that the right tool is not negotiated, it's deducted from the diagnosis, and the diagnosis is exactly what it does the characterization. Now I'd like to talk about a clinical case or a case of study. In Isomab, we have triple negative breast cancer, early stages, high risk, with a list price of around $2,320 per day. There are 17 cycles in total, with a total price per patient of $79,000. Before any negotiation agreement, we have to do evidence assessment. We did one with 7 years of follow-up, the biggest follow-up for this investigation. We do the evidence assessment, we calculate under the grade system, we calculate the budget and the implementation degree in the network. What were the results? We have medication for AAA negative breast cancer that affects young women mostly in productive age. that has a worse outcome than other types with a price of $79,000 per patient, with an estimated demand that's important for the public system, with an impact in the budget that could surpass $55 million. So the question that has to be answered by the health system is uncomfortable, but it's necessary nevertheless. We are finding something that might work, but we're not sure on how precise and within a system that can hardly sustain that. So the idea is to ask if it's necessary to finance pembrolizumab in triple negative breast cancer. So we do an analysis, and what are the results? Because the details of the model are not only for this webinar. So what do we have here? Pembrolizumab adds 1.47 quality or quality adjusted life year, the $79,000 a year. The result ICER is $48,000 per poly, almost three times the GDP of Chile, and which is a threshold that we have as a reference. The case is it's not effective, it's not cost effective. But before closing this, you perform deterministic analysis, and as we can see in the graph, the first thing that we see in the list is that the parameter that influences the most with a big difference is the extrapolation of survival rate with a range that goes up to almost $70,000 a year. So what do this tell us? That the uncertainty in this model is not distributed uniformly within the different parameters. It's concentrated in one, how much the patients survive without progressing that receive only chemotherapy or chemotherapy plus pembrolizumab. And that's the information that a clinical trial cannot give us with precision if there's a limited follow-up. So the decision will change depending on the threshold. It's important to highlight that in Chile, the decision of coverage does not happen when a recommendation based on a certain threshold or a certain reason that's not been pre-established. The decisions in Chile are taken by the authorities, and what the technical teams like ours do is to deliver as much material possible so that the decision can be done based on facts. So the question here, or the decision is going to change depending on the threshold that we have. And what can we see? The vertical axis, the possibility of being cost effective, and the other one is the willingness to pay. The dark blue is only chemotherapy with lower thresholds and start to fall progressively. The green one is pembrolizumab, which starts with zero and starts to go up. These are the thresholds of the GDPs, 1, 2, and 3. And we can see that one GDP, the possibility for this to be cost effective is 1.5%. So the decision will be to not finance. 2 GDP, the probability of being cost effective is 21.5, and a 3 GDP is 53.2%. So the answer, the base case, that's almost 3 times over the official threshold. Now, we know that the decision-making process not based on cost effectiveness, but instead of trying to optimize with net benefits the most optimal strategy. So what can we see here? What are the lower threshold? The lower the threshold, the decision is clear. We don't have to finance pembrolizumab, and we have to take the decision to maintain the patients in chemotherapy. It only when we have the willingness to pay over $47,000 per quality, both strategies in that zone have approximately 50% of probabilities of being cost effective. And where the strategy changes or where that border changes, then we'd have to change pembrolizumab would become the most optimal strategy. So the direct conclusion is that with the list price of pembrolizumab, it's not cost effective at any reasonable threshold. But the uncertainty continues being sufficiently big so that it's not right to remove it. So under this scenario, when there's a lot of uncertainty, shared risk agreement could be justifiable. But we have to understand that uncertainty has a price. How much is it worth to know more? And even though we understand that at 3 GDP, the possibility of being cost effective is 53%, but that probability does not respond to what the decision maker could care about. And it's how much that uncertainty costs to the system. Is it worthwhile to reduce that uncertainty? And for that, there are analysis or analysis frameworks like the value of information. The value of information gives us two metrics: the expected value of perfect information and the expected value of partial perfect information. So we have to understand, in order to avoid diving into details, the expected value of partial perfect information tells us how much a decision would improve if we knew the exact values of every parameter in the model. That would be that's the absolute price of A. The EVPPI is low, the uncertainty is costly for the patient. The other metric that's delivered to us is the EVPPI, which is the expected value of partial perfect information. And this drills down the uncertainty in subgroups of parameters. And what it delivers is information of where does uncertainty live in. And that's very important because it gives us the priorities of the research, because not all uncertainty deserve the same investment for doing research. And this is very important within shared risk agreements, because it tells what types of agreements we can design. If it's clinical based on an outcome, or if it's based on price, then it deserves a financial agreement. So the results of this analysis allows us to understand that out of the responsible groups of uncertainty that we have here, like survival, profit, the cost of drugs, the cost of the health, and the different events. In the horizontal axle, we have willingness to pay from 1, 2, and 3 GDP. The most important message lies in the red bars that are 1 GDP, which is our official threshold. All of them are invisible, basically. So survival, profit, cost of drugs, etc., all of them are close to zero. This confirms what we had seen before. And the threshold has no financial or relevant impact. The problem here is not the evidence, but the price. Now let's look at the blue bars. And the story changes here. The survival dominates in 73% of all the uncertainty. So we can ask a question here. What does it mean? What does this mean for designing a shared risk agreement? If the uncertainty lies on survival, the shared risk agreement would be based on outcome, on not on biomarkers or anything, but the observed survival in the patients. In Chile, we work with a public assistential network. So this allows us to understand that these analytic tools, will allow us to transform a technical question into a public policy in the future. This EVPPI transforms this technical question into a recommendation for designing. Not every evidence is worth. The evidence is worth based on the parameters that actually move those decisions. At 1 GDP, which is zero in another parameter, confirming that the barrier here is the price, not the evidence. And at 3 GDP, the survival concentrates 73.3% of the uncertainty that matters. So what does the analysis tell us? That the EVPI, is $200 per patient. The evidence is enough for deciding not to finance at the list price. And for crossing the threshold of one GDP, promotional lab requires of a discount of X percent on the price list, and this is the technical mandate for the negotiation. A financial arc with price negotiation, not with coverage or evidence generation, because this can only be justified if we have a threshold that's a little bit more flexible of at least 3 GDP. The final message is that technical capacity precedes everything. It's not enough to have a political framework or political willingness. Without technical capacity, without quality data or the governance, the ARC is going to fail in its execution, even if it's properly designed. Something else that risk characterization based on the diagnosis of uncertainty is dominant and has to occur before negotiating, not before or after, because risk characterization is an instrument that is the outcome. It's not negotiating. The value of information can turn a technical question into a public policy recommendation. Thank you. Thank you, Rodrigo, for your presentation. It was very clear and very complete. And the experience that Chile has is very valuable for the countries of the region. And now let's go to our last speaker, Luis Belostrador from the Ministry of Health from Argentina. He's a pharmacist. He also does pharmacy, pharmacoeconomy, and hospital resource optimization. Currently, he is the National Director of HTA in the Ministry of Health of Argentina. He's also a professor in the university and assessment of HTA. Luis, I'm looking at time, so we have 10 to 15 minutes for the presentation, and then we have 15 minutes for Q&A. So go ahead, you have the floor. Thank you very much, Caroline. I'm going to make an effort to try and not to go over the time. Can you see the presentation? Excellent. So based on what the previous speakers have already said, it's important to make a reference about the specificities that our health system has in Argentina. Our health system is conformed by three subsectors. One sector is public, which is financed by the taxes that are paid by every citizen. And there are two subsectors. One is for Social Security, and the source of financing comes from the payments of the workers. And the third subsector is the private subsector, where the payments come from the users. There are situations where these three sectors interact, and the people can belong to one or the other subsector and receive coverage regardless of their work situation. There are people who have coverage from social security, and they can have they can be received by a prepaid medicine system, but the ones that have a more complicated position is the ones that have exclusive coverage, and the only alternative for receiving treatment in these cases is through the coverage that can be offered by the government. So bearing this in mind, in Argentina, we do not have a threshold for determining the coverage or not of a certain technology. We have the health technology assessment is called Conatec in Argentina that issues recommendations, but they're not mandatory. So compared to what the NICE does in England or compared to what Chile does in Argentina, we do not have a threshold, and the coverage is it will be determined by the subsector that the patient belongs to. And due to the cost of certain technologies, the decision of not giving coverage it takes the case to the legal system. And these drugs that are judicialized it do not have a price agreement that allows its financing. And this is what gave birth to this agreement that I'm going to talk about, which is the shared risk agreement signed with Novartis in Argentina. The Conatec made a first assessment on Solhensma. It's a big word. It's called Onacenogen aviparvovec, but we're going to call it Solhensma from now on. The first assessment done by Conatec was in 2018, and it did not issue a positive recommendation. It did not recommend the coverage of the drug because of the cost. But until that moment, the options that people had that had SME or spinal muscular atrophy had to be taken to um, court. So there were negotiations between the government and the laboratory until in 2023 we achieved the first agreement of risk share or shared risk celebrated with Novartis for procuring Zolgensma for treating the spinal muscular atrophy or SMA. This is a reference to the pathology. So SMA is a disease caused by the mutation of a gene that produces a protein. When this protein is absent, then motor neurons are affected that can end, depending on the age of the diagnosis and the severity of the symptoms, in four different clinical types of SMA: type 1, 2, 3, and 4. And type 1 SMA, which is diagnosed before the 6 months of age, and the babies that are affected by this disease have little control of their head, and they have motor this motor problems, and this affects their development. Then there's SMA type 2, 3, and 4. And depending on the classification and the age of the diagnosis and the severity of the symptoms. Before 2016, I think that the first drug that was approved was called Lucidez in Argentina in 2019, nusinersen. But currently, there are three approved treatments by ANMAT in Argentina. ANMAT is the regulatory agency that approves and gives the guidelines for the commercialization of the drugs, but it does not fix a threshold for the coverage. So Argentina approved three different treatments for type 1 SMA, nusinersen, Zolgensma, and risdiplam. And some of these drugs, especially nusinersen, achieved the coverage for other types of SMAs. Zolgensma is recommended only for patients that have type 1 SMA and that have to be under 2 years of age. The dosage is just one, where a functional strain of the gene for survival of the motor neuron is introduced through a virus, and this treatment has just one dosage, one application, one dose. The cost of this treatment is of approximately $2 million. So, regardless of what is the coverage that the patient has, either if it's public, exclusively public storage, or they belong to a prepaid system, this is going to generate a high impact in terms of finances. And this leads to challenges regarding the sustainability of the system for covering these types of treatments. That's why the agreement signed in 2023 not only means a financial cost, but it also allowed to give coverage to people in any of the three subsectors of the health system in Argentina. So in 2023, they achieved the first agreement for procuring 12 units of the medicine of the drug, and the payment of each one of these units would be subject to the evolution of the treatment. So Conitec participated in the development of the clinical criteria that have to be covered, that the patient has to have in order to continue with the treatment so that they can receive this disbursement by the government. So there were clinical milestones that had to be set that the patient has to reach related to his respiratory situation, his motor capacity. And the agreement establishes that if these things are not achieved in the following assessment, the government should not pay for this. But thanks to the learnings in this first agreement in 2023, in 2025, we were able to have a new agreement that led to the procurement of 12 additional units of Torresma with a lower price, lower than what we had to pay before when the case was in the courts. So this allowed for the patients to have access to coverage. This new risk shared risk agreement gives a has a pay per sold scheme, and each one of these payments are based on the reports that are done through a commission that I will present afterwards. And this helps to reduce the uncertainty on the effectiveness of the drug related to the payment of the drug. And this new agreement signed in 2025 that has some differences compared to the first agreement is a milestone in the history of coverage for these types of therapies in the region, and it shows the willingness of the different stakeholders. The laboratory always had the willingness to meet with the Ministry of Health and to give access to people to these types of innovations in order to continue working in an articulate way to favor the patients and their families. Conitec help with the inclusion criterion so that the patients can be covered under this modality. And the patients have to comply with the strict clinical criteria that include genetic diagnosis and clinical conditions that are very specific. These conditions, and I'm also talking about something that, I will also talk about something that was commented before regarding the need of collecting data. In Argentina, the CONAME was created, the National Commission for Giving Follow-up to Patients that have SMA, and this commission was created in 2023 for patients that have spinal muscular atrophy. One of the annexes include the inclusion criteria so that the patients can have access to coverage through these type of agreements. And regarding the payment, it was determined that based on the compliance of these clinical milestones, that this should be assessed by Conitec. And there should be also evaluations in the beginning to see if the patient had the inclusion criteria, and then after 12, 18, 24, 36, and 48 months after the infusion. So CONAME, the commission that was created for the assessment, the patients have to first ask for the enrollment, then registry was created, something called ROTAME, which is a registry for these technologies, and the patients have to request their enrollment there, and these cases are assessed in the CONAME, and if they comply with the criteria for eligibility, the patients can be enrolled so that they can receive the treatment through this shared risk agreement. So I brought a case here to show how the Konami works. In this case, this patient complies with the criterion for where is this. This is a patient with type 1 SMA who was 2 years and 8 months old at that moment. It had a coverage. He was registered and enrolled in the program. The first infusion was done in 2023 in December. And then the following assessments were carried out, making sure if the clinical milestones were covered. And after the first assessment, after 12 months, after complying with the clinical milestones, the disbursement of the payment was authorized, and after 18 months and after 24 months also, and so on and so forth. The patient continued evolving positively, and the CONAMI that meets on a monthly basis revises the cases related to the period, and in case that the patient achieved established clinical milestones, then the disbursement of the payment is authorized. The Ministry of Health and the CONAMI, with this multi-sectoral commission, does the assessment of the patients, and but the laboratory also plays an important role there because they're responsible of not only supplying the logistical expenses of the maintenance of the cold chain, but also participates on the trainings of the centers when the infusion is carried out, but they do not participate in patient selection. And this strategy is very important for making sure that the assessment of the results, of the clinical results, has no bias. And this project that's subject to results establishes a payment based on results. And there was a donation for assessing 4 years. This responds to one of the questions asked about the necessity of collecting data and establishing how long this procedure will take. The current payment system, after the new agreement that was signed in 2025, it states that there has to be 5 payments. Once the patient arrives and it's approved by the CONAMI, then the first disbursement is done. Then there's an assessment after 12 months, another assessment 24 months after, another one after 18 months, but the payment is not conditioned in this one, and the next one is at 36 and 48 months. So depending on the result of the assessments performed by CONAMI, the disbursement of the payment will be authorized. From its implementation in this route, there has been 25 patients enrolled. Out of these patients, 17 were approved by the CONAMI. 6 did not comply with the eligibility requirements. They were rejected, and in 2 cases, additional information was requested for being able to assess if they complied or not with the requirements for enrolling them. Among the patients that were approved, 2 were not able, could not go into the program because they have clinical changes before the infusion. And up to date, there are 15 patients that have received infusion and that are currently under treatment. And the infusions are done in different centers within Argentina. The main center is the Hospital Garrahan, that's in the federal capital, but there are other centers throughout Argentina where the infusion is done. The main characteristic is the universal coverage that this program has. The Argentina model has norms, have norms, financial, clinical, and normative tools, allowing sustainability and equity. And this is applicable to disruptive technologies with a high cost, like the case of Sorhelsa. In this case, the coverage does not differentiate the subsectors of the health system and which one the patient belongs to. They just give a coverage to any patient that asked for being enrolled through the route, and that it's approved by the economy that complies with the eligibility criterion for being admitted. And as a conclusion, and I was able to do this in 10 minutes. This program payment based on results implements this mechanism of innovative access based on evidence, regulation, governance, and that are aligned with the universal coverage principles for health. I would like to highlight also the participation of the CONEPEG, the National Commission for the Assessment of Sanitary Technologies, that not only help with the recommendation regarding the coverage, but also with the development of the clinical milestones that the patients have to comply with in order to obtain the coverage. Thank you very much to the PAO for giving the opportunity to be in this seminar. And I'm open to questions if there are any. Thank you very much. Thank you very much, Luis. Excellent presentation. It was very interesting. This is Argentina's successful experience, and thank you very much for all of you. And now we have a small, some time for Q&A. Unfortunately, due to a force majeure issue, Rodrigo could not stay until the end of the session, but he'll be able to answer your questions through email if you want. So I tried to collect some questions here so that we can answer as many of them as we can. One of the questions that was what's the price or the sustainability of increasing these types of agreements for England or the Argentinian health system? I don't think that one has the price of how much this is worth for the NHS. That probably Luis or Juan might have some feedback. Juan, if you allow me, I would like to say that before implementing the first program, the market price of Sorhesma was approximately $2 million. The first agreement that was achieved in 2023, and we were able to pay a lower price for the first 12 kits. The price was approximately $1.5 million. And the new agreement, the one that was signed in 2025, thanks to the experience that we obtained, and after revising the inclusion criteria, we dropped the price to $1.1 million per infusion. A significant difference compared to what we paid before. And I would like to highlight also that in Argentina, there's not a threshold that determines if there's going to be coverage or not of this drug. Thank you, Luis. Juan, would you like to say something? Can you hear me? I don't have the exact cost of these agreements, but if these means there's going to be a significant savings in the price, probably the cost can be assumed by this type of agreements. In NICE, we have a team dedicated to these types of agreements, which are the ones that monitor how the therapies that require data collection and how they comply with the parameters that we have in the provisional recommendation. That team is fully dedicated to that. And in relation to what Rodrigo said, this also gives us institutional memory. It allows for not only to depend on one person that has the experience implementing it, but when having a team with the standards, then we have institutional memory for whenever people uh, need these types of agreements. There was a question regarding type of diseases, and uh, most of the experiences are based on oncology or not, are diseases that are not that frequent. But can this also be applied in chronic diseases that in fact impact the patients? I don't know if NICE has an example of this. Most of the cases that we see are either oncological therapies or rare diseases. Certainly, the impact of the quality of life is within the agreements for data collection as one of the most important points. And I would not know if there are examples where that has been the main data point, or if there are other pathologies that are more chronic in nature, but I could consult that and give you an answer. But the country has to decide if they want to do this based on the pathology or if they want to do this on general trends, which is what we try to do when creating the fund of innovative non-oncological drugs in order to avoid creating this dichotomy between cancer and the rest of pathologies. Thank you, Juan. Another question, and how do you do the financial confidentiality process during and in the end of the agreement when this ends? In Argentina, everything's published, and in NICE, it depends on the case. Yes, in England, the companies have flexibility. They can put the price that they want when launching when rolling out in England, but most of them has a confidential discount for being able to be cost effective for the national public health system. So, and the access agreements, the plan or the points that are going to be collected are public, and the commercial agreement is confidential. So many times uh, they publish an agreement that's they show that there's an agreement, but it's confidential, cannot be published. And regarding how the company publishes data, it depends on the agreement, and then they determine what data does the company believe that is confidential when establishing. When the guidelines are published, there is data that are confidential, but can be published afterwards in a journal that's peer reviewed. In the case of Argentina, the CONAME keeps the identity of the patient, and regarding the values, they are public, and they are published in the webpage of the Ministry of Health, and the values were published on different media. So they're public in nature, they are. Thank you. Thank you, Luis. And regarding data collection, there are some questions on who collects the data and if there is a minimal amount of data set that NICE recommends, Argentina recommends. We understand that yes, that data has to solve uncertainty in order to be useful. But Juan and Luis, if you want to go deeper, NICE does not have a minimum set of data per se, but it's the committee that decides who or what data is the minimum necessary. And the feasibility analysis that we did in the beginning determines if we are going to be able to do this or not. And regarding who collects the information, it can be follow-up periods of the trial. So in the case of oncology, the National System of Health collects basic data routinely, but it's very representative of the patients of oncology in the United Kingdom. This can collect survival data or free of progression in the oncological treatments. That database is used in those cases for other types of diseases. We try to use existing records in order to have more agility. But this is harder in non-oncological diseases because it's not standardized, and the data of the patient is strictly under confidentiality, complying with the risk criterion. In the case of Sorhesma, with agreement, there's a resolution establishes the guidelines for the inclusion of Sorhesma treatment. The guidelines are established, and what are the inclusion criterions? This has to do with the age, the atrophy level. If it's type 1 SMA, they have to have at least two copies of the gene. The gene produces two types of protein 1, protein 2. So we assess that there's at least two copies of the gene for survival. Has nine, it can be 9 months old when prescribed, and other criteria that are related to the respiratory performance. And the information is collected by CONAMI, the National Commission for the Assessment of these types of patients that have SMA or spinal muscular atrophy. Thank you, Luis. There was another question about the model, if the NICE model can be used in region like Latin America. What will be the limitations? What are the differences between what's being implemented and NICE with a lot of expertise, with a team that's fully dedicated to these agreements compared to the Ministry of Health of Argentina or Chile, where who have less capacities. But I don't know if Luis or Juan would like to say something. I just wanted to say that the importance of this agreement is that it was achieved. We were able to articulate the efforts and the wills of the financier, that was the Ministry of Health. They were they sat down to have an agreement to maintain the link with the laboratory, and that's what allows for these types of agreements to be replicated with other types of drugs, probably not with the same cost, but we could replicate the format and the model to collect data for follow-up. Thank you, Luis and Juan. There was a question about a hospital that did not reach agreements with the laboratories that said that they had no previous experience and they had a repository of laboratories that have this experience in the region. I don't think that they exist, but Luis, I don't know if you also know anything else, but I think that generally these agreements are published. For example, Luis, you mentioned that this was done with Novartis, and nice, you can also go to you can see the assessments and what agreements exist. And Rodrigo also shared the agreements that Chile signed in the country. And there are many questions. There are many questions regarding data collection, but what we understand is that in CAL, this is done by the institution through the physicians, and sometimes with databases, and the agreement is implemented. Then they have agreements with the hospital centers or the physicians or the national health system so that they collect the data. Or if it's part of the clinical trial that's being completed, it can be done through the pharmaceutical trial. Is what I'm saying, is it right to summarize? Yes, regarding to what we do with SMA in Argentina, the CONAME, which is the commission, is in charge of compiling the data or collecting data. There's a format that has to be completed by the physicians from the epicrisis to the clinical records that are sent. Once again, they determine whether the clinical milestones that have to be complied with, and then each assessment 12, 18, 24, 36, 34, 38, and they complete this model where they continue, they give follow up to the milestones depending on the compliance or not. That depending on the numbers depends on this. So, and after every meeting, the CONAME it meets once a month, every month, and we issue a report, and that report it becomes official, and that's where they record all of the data, and obviously with the confidentiality of every case. Thank you, Luis. And last question, because we are over the time. What happens at the end of the agreement, and especially if it's negative, like for example, having more data, I'm not able to for the technology to be cost effective or effective. Understand that in the case of knives, the patients that are already receiving the technology can be there and receive the treatment, so they can continue with the treatment. Is that right, Juan? Yes, that's right. The patients that were already under treatment, but it's closed with new patients. And Luis, in Argentina, for some healthcare, there's something like this. The disbursement depends on the assessment. There have been 4 patients that where the patient did not reach the clinical milestone, so the payment was not made. This happens at 12 months, and it's important to clarify that in spite of this, the patient continues under assessment. That dosage has to be administered, and the patient continues with the follow-up of CONAMI, and then the next assessment, for example, at 24 months, if they're able to reach the clinical milestone determined for that stage, then the government does disburse the money for the payment. Thank you, Luis and Juana. We're 5 minutes over the time, so we're going to have to close this webinar. There are many questions and a lot of interest, and I would like to thank once again our speakers for today for an excellent presentation. There was a lot of interest here. Thank you also for your attendance to everyone. And we're going to send the attendees this the slideshows because they're very interested. In a few days, you also receive the recording of the webinar. It's going to be available on the webpage of Redetsa. We'd also like to invite you to follow our social networks in order to be updated with the future trainings and webinars. And thank you to everyone and have a great weekend.